I'll give you heads up when you're about 15 minutes to finish. 10, 5 na time nyingine. Ina shida kingine kama kutakuwa kuna any certificate tutawapatia, tutafuta mtu mzito then ataenda kwa mtu kushtua kuna certificate kama ikiwepo ile just to appreciate wale walikuja kufanya nini WHO au certificate gani tafadhali? Yani CHS inatoa appreciation certificate for supporting the ni leo inaweza baada ya kumaliza kabisa session hii nitaangalia who is the head of the government ambaye did senior. Sure, everything will be okay. So start calling, lakini naomba kumsikiza kwanza IT. Sasa ndio angekuja hapa mbona ananitesa? Kuna kitu about presentation ndio maana nakuita.
Good afternoon, ladies and gentlemen. Karibuni sana. I think we are off close to our first quarter of the hour, so I'd like to invite you all to this plenary session, and it's with the Ministry of Health and WHO. And our session this afternoon is on the leveraging health sector strategic plan 5, the reviews of the midterm review that was done, and how this health sector strategic plan will shape the plans towards developing the health sector strategic plan 6. This afternoon, we have a panel of 4 presenters, and they are from the Ministry of Health of Tanzania, WHO, Ifakara Institute, as well as DPG Health, and this is from the Irish Embassy. I'd like to invite them at the podium as I introduce them. Thank you. So the first is Dr. Wananji, and he's a distinguished public health specialist with over 15 years of experience in the Tanzanian health sector. He's now the Minister of Health and has been a Director of Creative Services Acting and Assistant Director of Public Health Private Services, as well as Regional RMO and DMO under the PRLG. Currently, he's the head of the Health Sector Resource Secretariat at the Ministry of Health. Karibu sana, Dr. Wananji. And the next is Dr. Gabad Fejo, and he's from the Ministry of WHO, and he serves as the Health Systems Coordinator at the WHO Country Office, Tanzania. His major domain has been managing the primary health care services, quality improvement, health financing, results-based financing, leadership, and programming. He's now the officer in charge of the WHO office as we're waiting for the country representative. Thank you and welcome, Dr. Fejo. The next is Helen, and Helen Conihan is from the Embassy of Ireland, and Evan has extensive experience in malaria control, community health program management, technical support to public health programs, and capacity building. He's lived and worked in many countries in sub-Saharan Africa. Now he's joining the Department of Foreign Affairs and Trade, and he's also worked in the London School of Hygiene and Tropical Medicine, Medsan Frontier, Malaria Consortium, and so currently she is the head of development cooperation at the Embassy of Ireland in Dar es Salaam, and also the Embassy lead on health. Karibu Helen. And finally is Dr. Gertrude Moller, a colleague, a younger sister, pediatrician. She's a global health research scientist working at Ifakara Health Institute. She's currently the deputy head of Department of Health Systems Impact, Evaluation and Policy. Her area of instances are health systems strengthening in resource-limited settings, clinical research, particularly in the areas of child and adolescent health, guideline methodologies, and evaluation interventions. So she's been involved in the health sector strategic plan as a consultant in the service delivery thematic area. Karibu, Gertrude. So as we start this presentation, we'd like to share that the Health Sector Strategic Plan 5 it serves as an overarching framework of guiding Tanzania's health sector priorities. This is the mother document of the policies that are developed by the ministry into achieving the universal health coverage in the country, and also it's the Health Sector Strategic Plan midterm review was done in 2024, and we are now receiving the results. It has already been presented. However, we'd like to share the lessons that we've learned and how we're going to use those lessons while we're developing the next Health Strategic Plan 6. So our main aim is like disseminate what we learned and how you all can contribute, and your contributions will guide now the planning that we've already started on developing the health sector strategic 6. So I welcome you all, and Dr. Wamanji will start with the presentation to highlight what it was. So all of you who are not involved or not knowledgeable on this will get this a few insights on what happened and what transpired. Thank you.
Thank you very much. So I'll go very quick for those. I know not everyone who is aware, who knows the meet and review that was conducted this year. In the sector coordination, as she has said, the document that is guiding us, it has sector strategic plan. And then it started not today, but in 1999 when the country started to adopt what we call sector-wide approach or SWAP mechanisms, whereby partners together with the government will do planning together, but at the same time implementation and monitoring and evaluation. So one of the evaluation of how our sector is performing is the mid-term review that was conducted through the implementation of HHSP 5. So our review was done, thank for the WHO, but for mobilizing the resources, but at the same time, our Ifakara Health Institute, that they are able to do the meet-and review. Basically, the objective, it was to look at the implementation from the time in 2021 when we started up to June 2024, and it was a mixed method. And then how we did, basically they did the purposeful sampling. We sampled about 16 regions, but at the same time 3 districts based on the burden of the disease, but at the same time poverty index was one of the criteria that you used to select. So if you look at the objectives, basically it was to explore the relevance, awareness, and utility of HSP 5 among all the key stakeholders. But at the same time to assess policy alignment, service delivery, stakeholder engagement in development and execution of HSP 5, but also to assess health sector pace to the extent mobilization of the resources that are outlined in the HSP 5 and the recommended required modification or refinement, but also to assess the progress and factor that hinder access to accelerate the achievement of HSP 5. Last but not the least, to evaluate the effectiveness, efficiency, and the relevance and sustainability of strategy and intervention implemented. So if you look at the how the cycle, where we had several more than 8 thematic areas, we had inception, but at the same time, up to this juncture, this is one of the things that we are doing, dissemination of the. Why would we do the dissemination? Because one of the findings, if you could see, it shows the awareness. Most people, especially at the subnational level, are not aware about the HHSP. So that's why we say this time around when we are developing the HHSP 6, one of the things that we put emphasis for people to be aware that this document is there and this is a mother document for the. So coming to the very quick findings that we had, I've just chosen the impact level. Yes, we have done very good. Some of the indicators, we are on track. But we have managed to achieve the reduction of maternal mortality ratio, as you could see. We have reduced from 556 to 104. But still, there are some indicators that there's no progress. That we need to put more effort on those indicators, especially the HIV/AIDS indicators among the young people, PMTCT newborns, malaria prevalence among 6 to 59. months. Those are some of the areas that we need to put more effort. But another area that was very pertinent is the availability of data for NCDs. Still is a challenge because most of the data they are not really available. So looking into the, based on the thematic area, I'll go very quick. One of the areas that I've highlighted in the health policy and governance, it was awareness and utilization of HHSP5. Most limited, especially at the same, at the subnational level, most people, they were not really aware about HHSP5. So this time around, we want to ensure that everybody is on board during the development of HHP6. But another area, equitable access to healthcare, especially for adolescents and people with disability. Also, we have seen the issue of gender, physical and emotional violence against women and children. Still, it has remained prominent. But another aspect of the social determinant of health. Yes, we have done some efforts, especially now we're almost at the final developing the health and health policy framework. But at the subnational level, we have the primary healthcare committee guidelines, which is actually, it's like a vehicle, the vehicle to address the social determinants at the lower level. But also public and private partnership. It has shown a significant contribution to the sector. SWAP implementation, the one I've just highlighted. We have really, this is the 25th year where we are implementing the SWAP, and we have really enhanced the dialogue and accountability. I was not changing my slide, sorry. Okay. Okay, so coming to the SWAP implementation, as I've said, and the technical working group as well, we have done pretty good, but the governance and leadership capacity, still we have got an improved financing mechanism, especially for the through direct facility financing, transparent and local funds is still highly needed, but also coordination and duplication of effort. These are some of the challenges that were highlighted. In the case of the human resource for health, we could see some significant gap were noticed, especially in the distribution of the personnel. We have seen some of the rural areas, they have the shortage up to 66%. But coming to the system, there's a human resource for health information system has really improved, but there is a need to strengthen the HRH planning, especially integrating the staff workload indication staff needs. But also we have seen the government have done effort of increasing 70% of health facility, improve their working condition, but also we have seen over 76,000 health workers, they are benefiting from the digital CPD platform and so forth. But also we have seen the government expand and establish the financing, dedicated funding by DC. And also we have promoted the equity, especially to implement the gender sensitive leadership program. Some of you have heard in that the other room that we had a very good presentation on the GLASS project, which showed the leadership program how resistant. But coming to the health products as well, we have seen some improvement in terms of availability, but also we have seen the increase in the number of manufacturing, but still 70 or 80% of our commodities we are still importing outside our but the other challenge that was really significant is the workforce in the supply chain is still the gap that we're experiencing. Let's not moving. Okay. Slow moving. Can you press forward? Can you press forward, please? Okay. Other indicators, that is RMNSH. Of course, there are some of the targets that we have achieved, as you could see, ANC, antenatal, Penta 3, and the rest. But still, there are some other indicators that we need to push more effort, especially in the family planning, early NC booking, and the likes. Next. Next slide. Okay, as I've said, malaria, especially for the 6 to 59 months. Next slide, please. Next. malaria still, as I've said, we still have an issue, especially for the 6 to 59 months. The number is still high. Likewise, the HIV/AIDS, especially for the young, for the youth. Next slide. Coming to see the MNE and the ICT, yes, we have seen a lot of effort. Progress has been made in achieving health information system. Just recently also, the WHO that just shared Tanzania, we are the maturity level 4, we have scored 4 out of 5 with a score of 85%. So can you clap for everyone? Can you clap for Tanzania for doing very well in that area? So we're doing pretty good in that area. But also in healthcare financing, there are some gaps that we are really significantly short. But if you look at the enrollment of the insurance, we're still at the 15 point something. Here are also more efforts that need to be done as we will be implementing the UHI. So I believe some of these figures we believe that these are some of the issues that we'll be able to incorporate in our HSP6. Next. Coming to look at the issue of NCDs, non-communicable diseases, still really raising the number, alarming both mobility, next, and mortality. The numbers are increasing. So this is another area that we need to look to focus. If we really want to go for universal health insurance, these are the diseases that will really consume our funding that we have tried to set aside. Yes, the government have done some effort to put some funding for that, but if we not really do a lot of prevention, this should be another area that we need to look at. Next. So we need, yes, we have seen there's some progress that we have done, but quality, equity, and sustainability of our services is really pertinent. But now, back to the panel discussion whereby we will see how can we use the recommendations that were obtained from HSP6 and from the midterm review to be used in preparation of the health sector strategic plan 6. The one is supposed to be ready before June or before July 2026. So after saying this, I just wanted to take this very brief, but we have the full detailed midterm review. I think we share through the QRS code, so for everybody to read. So now at least all of us are on the same page. So when the panel will be posing some of the issue, at least I've just tried to highlight, so at least to bring everybody on board. After saying so, thank you very much. Back to you, Amanda.
Thank you, Dr. Amenji, for giving us some highlights. I hope we all saw what was done. And as he said, our colleagues will project the CARES code so that we can all get the main report and we can have reference to that and use it. So next, I would like to introduce Dr. Fejo, and he will have a few minutes to speak on the midterm review, and then Helen, and then Gertrude, and then we'll start the panel questions. Dr. Fejo.
Okay, thank you very much, Amanda. What can I add on what Dr. Amenji was saying already? I think one of the aspects that probably was overlooked, I'm trying to be the planning advisor, is the weakness. The weaknesses that we notice in the previous planning processes. As Dr. Amenji was saying, Tanzania was one of the pioneers in Africa in developing strategic plans, and for more than 30 years now, we are doing that in the country. But as you know, there are always improvements that can be done. And when we were assessing the previous plan, one of the first things we noticed was that the principles, the key principles, equity, sustainability, etc. And you remember, Dr. Bonaji mentioned that That was one of the weaknesses during the midterm review. Those principles were very well defined at the beginning of the document, but when you were looking at the strategies, you could not see how the principles were reflected in the strategies. So principles were defined, but overlooked. And why is it like that? Because in most of our documents, the what to do, the objectives were very well stated, but how to achieve is the most difficult. How do we really achieve those objectives? It's the most difficult. I think that's one thing we could notice when we were assessing the health sector strategic plan. And what is the consequence of that? The first consequence is trying to see the balance between the ambition and the feasibility. Because you have a very long list of things that we want to do. I think there were 30 strategic domains in the health sector strategic plan 5. The resources are limited, and we wonder how will we achieve all this, knowing that in addition to the main document, the different programs are also developing their own strategic plans. Some are aligned with the main document, others are not aligned. Fortunately for us, and you could see the progresses that Dr. Wonanji was presenting. Fortunately, so sometimes the government doesn't address the problems that are not included in the health sector strategic plan. I can give you examples. If you look at the health sector strategic plan 4, they did not plan for the construction of health facilities, but the number of district hospitals in the country were increased by 40%. In consequence, we could notice the huge reduction of maternal mortality, of child mortality, etc., etc. So sometimes the government don't even take into account our document when we are not very clear on how we will achieve the result. The other problem was the funding gaps and misalignment. I was talking about the alignment between the main document and the other documents. You go for instance, if you look at the costing of the health sector strategic plan 5, and you take the costing of various other documents, you will realize that the sum of the other documents is far, it's like 10 times the costing of the health sector strategic plan 5 itself. And why is it like that? Because we are repeating the same things. We have the human resource for health strategic plan, but when we are developing another document, we are addressing the human resource for health, just like if it was not addressed in the main document. When we develop the 1 plan 3, we address the human resource in the 1 plan 3, we address the financing in the 1 plan 3 without making any link with the main document. And that's why in the document it was already, this problem was known in 2020 when the plan was developed. And the Directorate of Policy and Planning recommended that all the programs should align the strategic plan to the main document. Unfortunately, and this is most of the time they're not driving, I'm not even driven by the Minister of Health, you still have a lot of documents that are not aligned with the process that the Directorate of Policy and Planning is doing. This will lead to the fragmentation and the difficulties in coordinating the implementation and the monitoring of all these plans. You will have the parallel disease control programs will not be systematically aligned with the health sector strategic plan 5, and they will have their own indicators, they will have their own mechanism of reporting, they will have their own cycle of evaluation, and that will not be taken into account by the Director of Policy and Planning, knowing that they are the ones speaking to the Minister of Finance. If you do not work with the Director of Policy and Planning, how will you get the funding from the government to address the issues that are raised in the various documents? The other aspect is the link, the intersectoral links. The the links between education, water, and nutrition are very weak in the health sector strategy. But it do not explain how we will do, knowing that the contribution of the poverty of education, of water and nutrition to the health of the population is far more than the contribution of hospitals and health centers. And by the way, if you take the national health policy, or if you take the health sector strategy plan itself, the overall objective is prosperity, it is well-being. It is not having the disease, it is thriving. And you can't thrive if you are not addressing the social determinant of health. The health system is not just about controlling the disease or treating people who are already sick. So I don't know if we should go to another panelist, right?
Thank you, Dr. Fejo. That was a very good take. Welcome in. Thank you very much. It's a privilege to be here representing the Development Partners Group in Health. So I was asked to really focus on the issues around fragmented financing and off-budget support, which of course is typically funding coming from various development partners. And I'm just going to share a few thoughts about how partners can adapt their approach a bit to really improve the alignment with the HSSP 5 and 6 that is coming. Certainly we have to acknowledge that off-budget funding can undermine transparency and coordination, particularly when you get to the local levels, and can make it a really onerous burden for those trying to deliver health services, having various reporting lines, various systems that they have to deal with. And it's also very difficult to keep track of that contribution. So we really do encourage partners, development partners in health, to channel their funds through on-budget mechanisms. Examples would include the Health Basket Fund, a likely World Bank multi-donor trust fund that's coming in health, etc., just to improve the alignment and get, where possible, to get the funding more on budget. It's important also to keep working to strengthen the existing mechanisms to improve the coordination through NGOs and multilaterals, and to make sure that they are aligning with the health sector planning and budgeting and the cycles, the national cycles on that. And we certainly encourage within the DPG partners to utilize the swap mechanisms that Dr. Mwangi talked about, including the technical working groups, to improve the coordination and as much as possible avoid duplication. Another approach which I think is very important is looking at institutional partnerships between the donor countries, the development partner countries, and also institutions here in Tanzania. If I could put my Irish hat on for a minute and mention one that we have with the National Irish Health Service delivery entity, the Health Service Executive, who partners with the Ministry of Health and PORAG in developing a curriculum and a framework for quality improvement of clinical service delivery. And that really enriches both members of that partnership and is a two-way collaboration. Of course, as is one of the recommendations in the MTR report, looking at how to strengthen domestic resource mobilization and looking at sustainable public-private partnerships to reduce dependency. The last point on this I'd just like to mention is really, and I think Dr. Fejo, you mentioned it as well, the challenges of parallel disease-specific programs, and really working very closely with the ministry and the government to strengthen integration of programs into the national service. We've seen all the impacts of the significant ODA cuts this year, and to strengthen the resilience and sustainability of the health service, this is really a high priority. Thank you so much. Thank you very much, Helen. Gertrude, with your experience as a consultant in working on the midterm review.
Thank you very much, and I'd love to acknowledge that I'm presenting not only Fakari Health Institute, but a team of 9 consultants from across the globe, but working looking at how far we've gone with HSSP5. And I'd just like to reflect that when HSSP5 implementation began in 2020, it was just a few months before the country was declared middle-income country. And that certainly came with a lot of expectations, not just from donors and who would receive waivers, but also from people who are being serviced by the sector, that we should get better in terms of service delivery, planning, and all aspects of health sector performance. And the rationale could be simply to look at how far we've done and to celebrate the wins and how much the government has done well in terms of health sector performance, like Dr. Ananji has highlighted. But it went beyond that, because reflecting again, during the time of HSSP5 implementation, there was a lot and there is still a lot of ongoing changes in context. That is when the country, just like the rest of the world, was hit by COVID-19, and then also ongoing outbreak. This is the opportunity to also learn how the country sustained service delivery and all other aspects of health sector performance amidst that such changes in context, and the changes were pretty much unplanned. And I think we can all attest that Tanzania is among countries that did very bold and well in terms of sustaining health sector performance during that time. But now we're also observing changes in terms of financing and donor landscape that will be spoken by the expert, but it still has a lot of effects on how the health sector performs and a lot of lessons to learn on the process of planning HSSP6. So I was asked to reflect on the lessons that we can take on from the HSSP5 MTR. And as one thing I could say is that when we speak of health sector performance, it's very quick to jump into curative services. How do we treat the sick? And do they get well or not? But actually, when we speak of health sector performance, it spans from all aspects of the few who get sick, sliding through the prevention and promotion approaches, but also rehabilitation and palliation. And as we take lessons on to HSSP6 and we speak of equity, etc., we also need to have to make sure that there are very well articulated indicators in all these aspects, where the government and the sector can measure itself on how they're doing on promotion, prevention, articulated in the HSSP, but then, as Dr. Fejo was saying, reflecting in other plans and other documents, treating the health sector strategic plan as the mother document and the mother plan. Key lessons that we learned as well is about the use of routine data collected, routine health management information system. Dr. Ananji highlighted that we went into a sample of 8 regions across all the geographical zones of the country. We sampled facilities. We did primary data collection, secondary data analysis of trends and performance of the sector, did a lot of interviews with different level of patients, community health workers, etc., to really see how they take and how they would get the performance of health sector. But for every patient who is attended, there's a lesson to learn on how better you can do when you attend the next. So when we collected all this data that could be grouped as a research or survey, we also had to couple it with a lot of routine data that is being collected every day in our systems, and leveraging between the two, both the routine health information system and routinely collected data, together with research that is being conducted in terms like midterm review, but also ongoing evidence that is being produced and presented in country day after day, is very important guiding. It's very important in terms of guiding the planning of the health sector. But then not just planning with the health sector, we speak of sector-wide approach, and I like to carry the phrase that health lies beyond the health sector. If you have not showered because you don't have water, it affects your health, etc. So also clear indicators as we go into HSSP6 on the measurement of the sector-wide involvement and how each of the different sectors contribute to the gains that we see in the health sector. It's beyond how much we have engaged, but then how much is the engagement contributing in the gains that we have heard. But then another lesson that we can take on from HSSP5 MTR is subnational level implementation of plans and programs at the ministry. ministry plans for the country, but then there's a difference between dissemination of plans, programs, and distribution of plans and programs. So in the process of disseminating, not only, Dr. Onanji mentioned that there are stakeholders and people who are not aware about HSSP5 and what its role is in the health sector. So carrying from that, we need to take along the lessons that even the plans have to have clear plans on how they can be implemented at subnational level. And this also comes in terms of data use, disaggregation of data use to lowest level possible, so that planning can be relevant at each level of health sector that you're planning about. As I mentioned, it's very important for adaptability to changing contexts. We know that it's not going to be a promising future given what we are seeing. There are going to be challenges in funding, there are going to be new disease outbreaks, we're going to have to brace ourselves to adapt, but also to be able to sustain the services and to improve every day after day for the people who really looking to benefit from the services. Just to, for the last point for the debate here is about putting the community at the center, providing the services, but then the key lessons that we learned is about sustaining the quality of the services. I'll steal one of Dr. Fejo's very common phrases that I don't know if he knows that I remember. When he compares between the progress made in maternal mortality and why we're not doing well in neonatal mortality, we like to reflect on how the issue of improved access has led to improvement in maternal health. And these babies are born in the facilities. But if they're born in the facilities and we're not doing well in having them survive, thrive, and transform, then comes the issue of the quality that they receive. So assessment and continuous monitoring of the qualities that is being provided should not be undermined at all costs, because that's what will translate the efforts and investment made into the sector to the outcomes that we all envision to see in terms of leaving no one behind and ensuring quality livelihood for everyone. Thank you.
Thank you very much, Gertrude. I would like to ask Dr. Onanji, as the Minister of Health and all the experiences that you're getting as the planning department, and the gaps that are highlighted in the policy management, alignment and implementation. So what will the Ministry of Health do differently in the HSP6 that is coming on as we started its concept note? Thank you.
Yeah, thank you very much, Amanda, for a very good question that you've just highlighted. The thing that we are going to do, that's what I've started. First is to disseminate the findings, that's number one. But at the moment, we're really coming at the very right moment, whereby we have already the Vision 2050 is in place, long-term perspective plan, but at the same time, we are really updating our policy, but we didn't have the strategy. But at the same time, the strategy is being developed right now. So we'll make sure this HSP6 that we're developing right now is really tying with the strategy for our policy, that's one, but at the same time, engagement of all the key stakeholders from the planning process. But while we'll be engaging them, at the same time we'll be disseminating these findings. So we are going to maintain the gain that we have obtained, but at the same time we are going to address some of the challenge that the colleagues they've just highlighted in terms of fragmentation, in terms of planning and whatnot. I could give a very valid example. Last year when I came to the Ministry of Health back coordinating the sector, there's so much outcry there about the TWG, technical working groups, are not really functioning and whatnot. But what I came to realize, there was misalignment between the planning and the planning and the budget allocation for the technical working groups. The planning was there, but they were not linked to the budget. So this time around, we have said, no, we need to line the plan of action of our partners, the plan of action of our government, and all the resources to implement that. That's number one. So the same time to the HSP6, as I've said, in Tanzania, this is the 25th year. We have the common management arrangement. So we're going to come up with a new common management arrangement to be able to guide us for the implementation of HSP6. And luckily, another document that is guiding us as well is the Development Cooperation Framework under the Ministry of Finance, which the new one is already out there. It has addressed some of the issues that we have not pointed out, the issue of climate and health. We've seen now how, because we don't really have the proper plan and addressing that, there's a lot of issues, even malaria rebounding and all those. So all these are some of the issues that will be incorporated. But on top of that, we have spoken about the issue of integration. But the integration is not going to start at the implementation level. It's going to start from the national level. How are we going to harmonize all those things to be integrated? I know even in the verticalism, we have all those technical, but how can we align at the national level at the same time at the sub-national? That's some of the area that we are going to address. So when we, and then at the same time, another thing, now you have been highlighting, we have a strategic plan. We said those are not going to be the strategic plan, rather they will be the roadmap or implementation plan of the bigger health sector strategic plan 6. So by doing so, I believe we'll be able to do so. Even when we come next year, because like our dialogue is starting basically from the implementation side. So we believe in the implementation. They have already a strategy from 2022 to 2032. So we believe some of the issues that we'll be incorporating, it will be from the implementation level, but at the same time when you come to the technical level, up to the policy level, there will be alignment. So this is what I do. But it cannot happen if all of us, we don't speak the same language. So we need to speak the same language now when we're developing the HSP6, so that we ensure that we make sure that we integrate all those issues that are supposed to be incorporated. Yeah, thank you.
I'd like to add something on your response. One of the things that you also mentioned was that it was not well taken by the other sectors, and the lower level implementers are also not aware of the health sector strategic plan. And we know that one of the other things is our language. Does Kiswahili play any importance in dissemination of the health sector strategic plan, and how are we taking it with the health sector strategic 6?
Yeah, thank you very much. First of all, the findings for midterm review it shows the language that you're using is it was very tedious. So this time around, we make sure that we come up with a very simple language. Even the translation is especially for the subnational level, Swahili if possible. But another aspect that we really didn't get it during the process is the theory of change. So this time around, we'll make sure that the consultant, they really do deep dive on the theory of change to come up with really actionable matrix in our HSP6. Thank you.
Thank you very much. Dr. Fejo, I would like you to also speak about your baby area, universal health coverage. You haven't spoken a lot about that when you're explaining how the health sector strategic plan 5 and how the lessons can take into the health sector strategic 6 in line with the universal health coverage. Of course, you're going to mention financing, universal health financing. Thank you.
Okay, thank you. I'm not sure I can answer that question in 5 minutes. I mean, if you ask me to speak about the universal health coverage, but let me try. Let me put it this way. What is the role of the health system? As I was saying, the first thing is people to thrive, isn't it? Promoting health, preventing the disease. That's one. Second thing, providing the services when we are already sick. And third thing, preventing people from against unexpected threats. If we can do those 3 things for everyone in Tanzania, it means we are achieving universal health coverage. But how do we reflect that in the health sectors, the next health sector strategic plan? My advice, I'm technical advisor. My advice will be to plan around the service delivery. What does this mean? I take the 3 aspects, promoting, protecting, and providing, and I divide it in priority. And you will have interventions to be implemented in the health facilities. You will have intervention to be implemented in the community, at home, policy interventions at national level, but it is important to clearly define what are those interventions. And that's the work Dr. Gertrude was doing. She's laughing. And I mean, she actually come out with a very nice list of interventions, the essential health interventions. The good thing in Tanzania is that the benefit package of the Universal Health Insurance by the Universal Health Insurance Act must be a subset of that essential health intervention package, which means if those interventions are very well defined and the health insurance is paying at least for the curative part of it, will remain the preventive part, the health promotion, rehabilitative, etc. And for me, what I will advise for the Health Sector Strategy Plan 6 will be, how do we effectively deliver these services to the population? It means not only having national solutions, but having targeted solutions, geographic targeted solutions. I remember one of the findings of the Health Sector Strategy Plan was that in Dar es Salaam, the kids and the mothers were more affected by the insufficient access to services than in the rural areas. Yes. Why? Because you cannot address the problems in Dar es Salaam like as you are addressing in Tabora. One size cannot fit all. How do we take into account those differences? How do we define targeted interventions per region in the next health sector strategy plan? That will be our main challenge, I think. But we can try. We can prioritize cost-effective, high-impact interventions. And that was done already with a lot of consultation with evidence-based prioritization. Now, what remains is, when at national level, we will clearly say we are focusing on primary healthcare services. These are the solutions. How will the governance support the delivery of services? How will the community engagement support the delivery of services? How will the human resource support the delivery of services? When we will have a plan that is designed like that, the next step will be at regional and district level now, asking our colleagues to develop 2 years or 3 years implementation plan. I can call it a coverage extension plan. Very simple document. How will I extend the services to people who are not benefiting from those services now? Because if we have only the national plan, it's very difficult to really show the link between the plan that Dr. Wonanji is developing and the benefit of the population. But if you have in each district a coverage extension plan, that is a 3-year plan. And when they are developing the council comprehensive plan on a yearly basis, they are taking into account the element, the new services that should be added, or the quality improvement element, then we think that we can improve either our planning process and the implementation process, and we can affect the whole population.
Thank you very much, Helen. If there was one priority action that from the MTR of the Health Sector Strategic 5 that should be at the heart of the Health Sector Strategic 6, what could that be?
That's an excellent question, and not the one I expected you to ask me. I think I do really want to come back to the point about really improving alignment of all of the different initiatives into the health sector in Tanzania. And as I spoke about earlier, just really now I think the critical importance of strengthening integration of services. And Dr. Wananja, you rightly said that doesn't start at the bottom, but in another way, I think practically it does start at the bottom, because the people working in those health facilities are the ones who have to manage it, and they have to handle these different funding sources, these different approaches, different reporting, different supply chains, and they have to ensure that they're delivering an integrated service to whoever comes in to their health facility. Having said that, I absolutely agree with you. The whole system has to change as well to enable that to happen, so that ultimately, as we really navigate and adapt in the face of the significant shocks that the health system has had in the recent years, and looking at the challenges in increasing the budget in the health sector. We really need to learn how to do things most effectively on that. So I think that's the one, but it's very, very difficult, Amanda, at the same time to pick just one. I'm very tempted as well to go into the whole aspect, which all of the panelists mentioned, around social determinants for health, behavior change, and really how we adapt our services for people as opposed to numbers. Thank you.
Thank you, Helen. Gertrude, we've seen that collectively there were so many efforts. You being on the ground working on this one, and you want to ensure that no Tanzanian is left behind. That's it at your heart, starting with babies. That is from the rural, urban. We see urbanization, like places like Dar es Salaam, Mwanza, adolescents, elderly. Now it's a lifelong approach. And the vulnerable population or the groups, you don't want to leave anybody behind. So what would we do in the health sector strategic 6? Or how will we plan to add into the health sector strategic 6?
Thank you very much for a new question as well, testing me as my teacher, but I'll take it because it is really at heart. I think I will go with the importance of subnational planning, and I'll give an example to that by facts and numbers. So one of the findings that we found when we did the MTR is that the total number of health facilities in the country over the MTR time improved from 8,400 to 9,400, close to 9,400, which is good. I hope you're clapping. The number of facilities increased. Another reason to clap is that 75% of these facilities are owned by the government. Please clap again. And then, remembering that, I will tell you the situation in Dar when you now look regional-wise. In Dar es Salaam, we know it's a region with a population of 5.3 million. It's a region where every one of you, if you ask where you want to reside, will say it's the most developed region in the country, etc., so I'll reside in Dar. But then if you look at the population and the number of facilities in Dar, the story is exact opposite of what I've told you at the national level. In Dar es Salaam, with 5.3 million people, we have a population, health facility density of 1.2 per 10,000 population, or in simple terms, a population density per 1 kilometer square of 3,800 people. And we have around 668 health facilities in Dar es Salaam. But this time, 75% of the facilities in Dar es Salaam are owned by private sector. So when you look at the country level, you'll say, oh, we're doing very well. We are owning 73% of facilities. But when you look at Dar es Salaam, well, actually the government is owning only 1/4 of the facilities. And so for a person living at the urban sides of Temeke, this is very important on how they access health services, because they're not going to be able to go to the private sector. They depend on the primary health care, which are mainly owned by the government, and that's the entry point to the health services. So I will take that. One, the importance of subnational planning. It is very, very important. And then the second bit is, before stepping into even populating chapters of Health Sector Strategic Plan 6, Dr. Ananjo mentioned what I would add in as the first point, is that have a very actionable theory of change. That before you start the journey walking through implementing HSSP 6, you can sit down with it on a sheet of paper and be able to map how you are going to walk through everything that you want to achieve in the health sector. What are the processes? What are the mechanisms that are needed to be put in place? What are the investments that are needed? And then how you are going to achieve what you're set out to achieve. And then the last, for everything that the health sector wants to achieve, it should have a very clear and measurable indicator. Not on the numbers of the indicators, because we can have even 70 and 80, but when you look down and say which one are very measurable, at what level, and then to impact planning. Those are the key takeaways I'd say they should be really taken in consideration when planning HSSP 6.
Thank you very much, Gertrude. I would like to thank all of you for a very insightful takeaways. And of course, Dr. Onanji, I think you're taking notes as I am, because we are going into this, I'll say, like a rhino, try to kill all this thing up. Now, thank you all of you for listening, and I would like to invite you all for any questions. We've heard the inputs that we have from the health sector strategic plan, how we should align to the policy, how equity and data-driven decisions are important, leveraging on the routine data produced with resources, how system strengthening and sustainability is key, especially around service delivery and monitoring them, translating the monitoring with the efforts that have been put down, and then multi-sectoral action for the universal health coverage. As it was well put, health lies beyond the health sector, so we should include WASH, education, work very closely with the Ministry of Agriculture, because it all affects the whole it gives the whole perspective of health to come in place clearly. So with that, thank you. It's back. Thank you, Dr. Onanji, Dr. Fejo, Helen, and Gertrude. And I would like to invite you all for a round of questions, and then we can have more questions to them too. Thank you. I see Alex very high up, and Dr. at the end.
Yeah, thank you, colleagues. I think this has been one of the great sessions to learn about what we did in the last health sector strategic plan. My name is Alex. I'm coming from UNICEF. So I just wanted it's more of a comment or a question to where we finished up with Dr. Gertrude in terms of the urban. Urban programming is also one of the things that is deep down in my heart. So with the Tanzanian population more than, I think we are now around 40% living in the urban areas. And now in Tanzania, it's almost 9 cities are defined as urban, and the numbers is increasing. So I think programming in the urban is very, very important. And I wonder, and we took a lot of stock, deep stock when it comes to the way services are being delivered in the urban area, especially so in Dar es Salaam. So I was wondering, despite for the challenges that you have mentioned, Dr. Gertrude, in terms of the probably it might be issues around the planning for urban, how did we take a stock of how the services are being delivered in urban? We know the complexity of the urban population, the dynamics of the urban population, probably the models that we are delivering services in urban, we might need to relook into that models, because we are going into HSSP 5.6. We don't want to develop the strategies that is with our thinking that Tanzania populations are living in rural, vis-a-vis that more than 40, it will become to 50 to 60% they are living in the urban. So just wanted to take if we have enough stock in terms of the way the services are delivered in urban. And the referral systems as well in urban. We also see some of the challenges in terms of the referral system from primary healthcare levels to the other level of the service delivery. Otherwise, thank you again. It has been a great session.
Thank you. My name is Dr. Mary Maigi. I'm Director of Research Information and Regulatory Affairs at the National Institute for Medical Research. And would like to thank all the panelists and congratulate you for the wonderful session. That we've had many amazing things, and we understand that doing and coming up with that report is a lot of work. So mine is actually a plea. I don't know whether I can enter that into this team. I know Fejo has spoken this previously. Is that planning requires information, and information, you get data from routine data, but some of it needs to be commissioned research some of it to inform our strategy is population level, very resource intensive studies that need to be undertaken. So one of the gaps, I think, is the research part is not integrated into our health sector strategies. I come from the National Institute for Medical Research. We are responsible for developing the National Health Research Agenda. But I believe that we have that missed opportunity because the entire process of developing health sector strategy involves a lot of stakeholders. And during those discussions, you highlight on the areas, on the gaps, and I think it will be a very good opportunity to also highlight on the research that needs to be undertaken, but also what data, what indicators need to be collected at what time, when and where, and what should be routine, what should be population-based, and what should come from maybe commissioned implementation research in the hospital or other implementation agency or facilities. So I think our plea is to make sure that we engage that process and make sure that one of the chapters, it's a plea, so I can't say make sure, but I'm pleading to see that one of the chapters in the health sector strategic plan talks about the National Health Research Agenda so that it can respond to the needs of the sector. So currently where we are, because I sit on the desk, we collect and synthesize all the research information, but there is no platform for the information that we collect as the National Institute for Medical Research to input. I know one of the opening statements was there is no data, but there is data somewhere on a gold mine that we are sitting on that can actually be synthesized to inform the next implementation, and probably that needs to be pre-planned so that the resources for those commissioned research or routine data that needs to be collected can be well organized so that next time when you're evaluating, some of the information you can just get from a dashboard and you don't even actually need to go and collect raw data. So we are evolving, so it's my dream to see that maybe next we need to be evaluating at many time points, and that requires also information to flow in like that. But I understand that Dr. Wananji, you say there's a gap in NCD data. I understand when you're starting the process, the population data for NCD, the report was not yet out. So it's now out and you can populate, and we need to show where the issues are, where the gaps are for NCDs. But in general, congratulations, and it's a good start. It's a very good report. I've scanned through it. Thank you.
Thank you very much, Dr. Mary. So we'll take two more and then we'll have responses. There's one behind and one here.
Good evening, everyone. My name is Halima Yateri. I am a health and nutrition youth advocate. So this is also both a question and a plea. The review highlighted improvements in the reproductive, maternal nutrition, adolescent and nutrition, but the nutrition component is not well highlighted. There has been improvements in family planning and other related components. At the same time, there is a rising burden of non-communicable diseases, which leads to both morbidity and mortality. So my question is, will nutrition be improved or elevated into a more independent and significant component of the health sector strategic plan 6? Also, will it be elevated to combat both the rising burden of non-communicable diseases and as well as reproductive, maternal nutrition and adolescent health? Thank you.
Yes, good evening. My name is Godwin Kabalika. I'm the country director for Site Savers Tanzania. And I have to admit that I've come a bit late, so sorry. Sorry if what I'm going to ask will not be relevant for this session. But my interest is, I wanted to get a sense from you, Wananji, in terms of HSP5. Of course, I've been involved in the process of HSP5 development and also implementation. Site Savers is a key player in terms of supporting implementation of HSP5. I just want to get a sense in terms of the financing. How well has HSP5 been financed? Because now that I know we are moving into HSP6, which is good, and I commend the Ministry of Health for driving this. But it would be very important to understand the financing of the current one, and what are the learnings, what are the lessons that will inform better financing for the HSP6. Thank you.
Thank you very much, Godwin. I think I'll give a chance for the panelists to respond, and the first one was with Dr. Gertrude. It was both a comment as well as like a question. Like, are we taking the stock of the services in the urban, and how are we positioned for urban programming? I think that's in short.
Yes, thank you very much, Mr. President of PAT, for the question. And yeah, so among the recommendations and the lessons that we learned from HSSP5 is how urban poverty has a negative effect on access to health by the people who are presumed to be living in better conditions in urban areas than those in rural areas. And HSSP5, MTR, has highlighted hotspots on where we should actually direct or plan specifically for this area, including Dar es Salaam and other growing cities. Because, for example, if you think about the planning of the access to services in Tanzania, I'll give you an example of, we have the RRH, Mana, Mwananyamala, Temeke. And all these regional referral hospitals are offering the same package of care across all, professions or all specialties. We thought about, given the distribution of population and the population density of 3,000 per kilometer square, shouldn't it be better if these centers are organized into centers of excellence, so that then those who, let's say, require maternal newborn child specialized care could go to one of the facilities, and the rest, and let's say cardiovascular NCD related care could go to Mwananyamala, and then another could go to the other hospital. This would have a lot of effects in terms of waiting time, planning, investment. If you were to buy dialysis machines, would you put in all the facilities? So all those have been highlighted in terms of consideration and deliberation when planning for HSSP6. And the bottom line lesson was that when planning for health service delivery and access to service in urban areas, you think about those residing in urban areas, which are most of the time overpopulated, and those coming from the rest of the countries to seek for referral services or better diagnostics in the city as well. So you have two populations there, and consideration in terms of planning service delivery should be specific and take into account these issues. And urban poverty has negative effects in access of all levels of care, including reproductive, maternal, newborn child health, NCD care, infections in terms of prevention, health promotion, but also them accessing the curative services. So that's what I would say in short, that yes, urban sites need specific planning in terms of health service delivery. And thank you, Dr. Mary, for also the plea and the question. And it is really important in terms of when you speak of duplication of efforts and resources, it is a waste of resources going to the field today to collect data that could have been, synthesized using the available evidence already. And so strengthening also, this comes as a plea back to your office, also strengthening the capacity for evidence synthesis in the country, because as a researcher, we think of publication as the end point, but then synthesizing the research that has been done in the country, but then it doesn't end there. How do we translate this and communicate this to different groups of stakeholders for the evidence. When communicating the evidence to the ministry, it is different to how we communicate the evidence to, fellow researchers, and it is different to how we communicate this evidence to, my grandmother and my aunt at home when you want them to understand that there is a rise in NCD. So we need to build this capacity and continue thinking about this in country, so that in terms of planning, it is not just about recognizing that research is being done, but then also putting effort in making sure that we utilize the evidence that has been produced in country, and it influences the planning, whenever relevant. I think those two were.
Yeah, thank you. I think with the part of what Dr. Mary was asking, I would also invite Dr. Fejo and Wananji to respond on that part.
No, I mean,
a little bit.
No, what Dr. Mary was saying, it's obvious. I think not only collecting data, but using data for decision making is crucial for our countries, not only for Tanzania, for all African countries. And we could leverage on the digitization really to improve the way we are collecting data, the way we are analyzing data, etc. I remember 20 years ago, I was discussing with a director of planning, and he was saying if in Africa we were trying first to have the land phone, and then later we come with the cell phone, we will not have any phone as we are speaking now. Same with the bank account. We all have a bank account in our mobile phone today. I think we have the opportunity on leveraging on the technology now and inventing solutions. And I was reading an article yesterday on Tanzania. They were saying that Tanzania is one of the countries in Africa where you have the most important innovations in terms of technology. It's really time for us to think about innovative way of collecting, analyzing, and effectively using data for decision making, because that's the issue. Sometimes we have a lot of data, a lot of publication, either from NIMRI, FACARA, etc. But are we really using it in the Ministry of Health, at PORALC, in the districts? That's a question. So, but there are improvement. There are a lot of improvement. If you check the Tanzania Health profile on the website of the Ministry of Health, really, in my work, 70% of the data I need, I can access on Tanzania Health profile, and it is updated every quarter, which is a very good progress for the Ministry of Health. You don't have many countries in sub-Saharan Africa in which you can have access to the data like that. The same innovation could help solving the problem in the urban area. I think Gertrude have explained a bit, but I was district health officer, either in the rural area and later in an urban area. And when I was district officer in an urban area, I had the funds to build a dispensary. I could not have a plot. I don't know in Tanzania, but yes, I could not just build it because there was no plot. I ended up trying to locate the dispensary in a rural or in a suburban area in my district. Yes, which means if we really want to improve the access in urban area, we have to think out of the box. You have several problems that are in urban area that you will not have in rural area. A lot of graduates from training school, from medical schools, who are not employed, or who are, I don't know in Tanzania, but in my country, they are paying doctors $100 per month. It's becoming dangerous. You have dual employment. I always say, when my son is sick, why should I go to a private hospital? Because the doctor I will find in the private hospital is almost always someone from Muhimbili, if you want to get the best doctor. But still, you have that issue, and we cannot pretend that the issue doesn't exist. How do we sort out that problem? How do we use this qualified doctor in the urban area? I'm just thinking a lot. Why don't we think about things like Uber or Bolt for the health sector? Having an app where you can click and then you get a doctor who is coming to your house, and in a more regulated manner. How don't we improve the home-based care in the urban area? Should we still have community health workers who are secondary 4 plus 3 weeks of training in urban areas when we already have nurses, midwives, and doctors who are not getting the job? I think these are things that should be addressed going forward in the health sector strategy plan 6. Dr. Wenanji, over to you.
Thank you very much, Dr. Fedio, and thank you everyone for a very insightful question that you've just posed. Basically, Alex, you've pointed out a very valid question. All of you are aware, come 2050, Tanzania, we are heading to be upper middle income countries. What does it mean? Means even almost 50, more than 50% of the people, they'll be living into the urban settings. So if they'll be living into urban settings, what needs to be done? One of the things that I've highlighted during my presentation, I spoke about health in all policies framework. Means other issues is not the mandate of that sector to do. For example, you're talking about planning, town planning, You're talking about all these other things. So when we engage with other sector, putting health as a priority, definitely some of these issues need to be addressed like that. But at the same time, we need to think, come up with innovative financing. Cities like Dar es Salaam or urban cities, how do we financing our healthcare system? Can we go to public-private partnership? Can we go to those who are innovative? Because one of the biggest challenge in the cities like Dar es Salaam, especially for the urban poor, is access because of the affordability. You've just highlighted over 80% of the facilities are owned by the private. So it will be very difficult for access for those people who are poor. That's why if you look at the indicators in Dar es Salaam, come to see maternal, come to see Nonet is an issue. So in the HSP 6, these are some of the things that we want to look upon. We know that in HSP 5 or 4, we said even the regions, the districts in Dar es Salaam, like the police, the way they've just highlighted, they call them regions. So Dar es Salaam is supposed to be treated differently from other. So these are some of the issues that we want to address in our HSP 6. So we have pointed out a very valid question, like looking at the modality. How are we going to purchase the service during the implementation of HI in the settings of Dar es Salaam? So these are some of the things that we want them to come out very clear in that way. Coming to the agenda of the research, I do agree with you. Somewhere, somehow, we have not been doing very well, part and parcel. We have a very good and palatable system, SWAP, sector-wide approach, whereby dialogues have been done from the implementation level up to the national level. So, what we are just advocating, and then I believe that when it has to come very clearly, we want this component of the research from the implementation. Luckily, this time around, we have started the medical in charges. They are definitely presenting the abstract best practice and what. So we want to pick some of the gaps that they need research so we could address right there. Because the gap that is, if that needs for the research is not demand driven, you're just posing the findings, therefore they'll not be used. But if we start from the implementation, coming to the technical level, during our dialogue, we really need facts, we need evidence to support us to come out with the policy. So if, what I could say right now, I believe that we're going to have a tripartite, that the researchers, you develop evidence, and we policymakers, together with implementers, we use those evidence to be able to, and that's a practice. Somewhere, somehow, so I think those are some of the issues that we want them to come very clearly during the not only the planning, but even the implementation. So you are part and parcel of disseminating your findings. Not like just the community of research and you're just sitting yourself disseminating the findings. Therefore, those findings will not be utilized. So we want to be very robust, and then namely, you are a champion of that. And because the NCD that we have got so many, like Tanzania, we have so many good practices. But if we don't really share and you don't consume those evidence, definitely will not be able to move on. So I encourage you to be part and parcel of this time when you are developing this HFP6. Let this agenda also come at clearly the tripartite, I mean the researcher, the policy, and the implementers. Let us work side by side to ensure that everything is moving smoothly. Coming again to the question of my colleague, Godwin Kabalika. the funding for the HSSP6. You have just heard yourself what we have just said. We had the parity strategy, they were auto-costed. If you look at the finding, they've got very big figures, more than what is there. So that, I cannot really tell you direct. What I could tell you significantly in terms of numbers of funding, we have increased a little bit. But if you look like in terms of the GDP in percentage, we have not done very much. But this time around, that's why we want HSSP6. We want to mobilize, I mean, to be used really as a resource mob tool, to be able to mobilize those resources, and we'll be able to track those resources where they're going. This is where we want to do, not like the way it was in the fragmented manner. We want to harmonize, we want to align all those things for the things to move clearly as the way you have just said. So we have a lot of expectation for the HSSP6, so I believe we'll be able to do that. So thank you very much. Okay.
If you allow 1 minute on the financing part, there was a specific report on the high financing thematic area, and I think you can take the address of Amanda, and she will share that report with you. But going forward, as Dr. Wonanje is explaining, we realized that having clear milestone for the financing was very difficult, and for the health sector strategy plan 6, we will try to improve to have a specific business case with very clear milestone that can be monitored going forward. But there was also one question that
from nutrition. Do you want to help us?
Exactly.
Thank you.
As you know, nutrition is not a health sector problem per se. And that's why when you are working on the health sector strategic plan, it's very difficult to highlight the nutrition only. We have multi-sectoral nutrition program in the country, and they have a specific strategic plan. And I think it's under the office of the Prime Minister, isn't it? Yes. And when we are working on the health sector strategic plan, we don't want to duplicate the efforts, because all the efforts about the nutrition, and it's involved the other ministries. They are working on that on that multi-sectoral strategic plan, even in our dedicated staff, but they are working with that team. And for more information on nutrition as well, I think we can share the plan and the data that they are producing. Thank you.
Yeah, thank you, Halima.
Just to add, sorry, I forgot that one. What I've just pointed out, health in all policies framework is to address social determinant of health, and nutrition is one of them. So we believe, as we're moving ahead, I know even in the development partners group, they have got development partners group nutrition. They have gotten all those things. So we want as much as possible to harmonize these efforts. When we are addressing social determinant of health, it means even nutrition, poverty, and all those things we need to address in the holistic. Because the focus here is that individuals, people-centered, that person that we want to was indefinite. By doing so, we'll be able to address issues like non-communicable diseases, like the one you have just pointed it out. Thank you.
Thank you. Helen, do you have anything to say, especially on the part of nutrition?
Yeah, actually, I think nutrition fits into what I would just like to do is bring this session back to the theme of the whole summit and digitalization and the role of digitalization in the health services. And I think that's really something that has gone at extraordinary speed, I would say, in the last decade. And the capacity and the innovations that are out there, they're really transformative. So I think within the new HSSP 6, the digitalization aspect is going to be critical, and it addresses all of those points that came up just in the questions. The one, the point about urban health, and it comes back to, I think, Dr. Fejo, you said it earlier, having the capacity to do directed interventions and being able to really understand, being able to collect data at source, having access to it immediately. I think that's a huge change in the capacity of the health service to be able to respond to the reality and be able to develop the capacity to then put the resources where the need really is. I think nutrition comes into that. I know that WHO in countries that we also collaborate with them on are working very hard on nutrition, to get nutrition as part of the DHIS too, so to collect routine nutrition data. At the moment, typically nutrition profiles are when you do a large-scale nutrition survey. That's a snapshot. You're not getting that ongoing information, be able to do, and the capacity to do the analysis where the data is collected. That's now a fantastic change. So each health facility has the capacity to be able to show what's happening in its own area, show its own community the trends, and be able, the community is then empowered to use that. There's more accountability. There's still a lot to do, and I think within the health HSSP 6, really seeing how the interoperability can be reinforced so that all of these clever systems are talking to each other. And again, for the end user, they become an assistance rather than a burden. So thank you.
Thank you very much, Helen. I think, Halima, that was well put. Guys, I think we're running out of time. I am not sure there is any other question, but I would like to really thank you all colleagues, my panelists here, as well as all the other partners who have made this possible, in engaging in this very important dialogue, and also for the insightful and very enriched information that we've shared to reflect on not only the lessons that we've learned from the midterm review, but also on the collective resolve colleagues have shared and how research can be used and how we can shape people-centered and data-driven health sector strategic 6. So your presence here also demonstrates how we are trying to advance in universal health coverage in Tanzania, just not only the task of an institution, but it's shared commitment with the government, with partners, with academia, with research institutions, as well as our communities. Those are the parts that we were really going to put our efforts in the health sector strategic 6. So we see that the MTR was not just a review, but rather a springboard and inclusive of all the data that we've learned from and will use into health sector strategic 6. Thank you very much, and I wish you a very good evening. And please scan the QR code, and I will share my email for those who are interested. As Dr. Wananji's second slide, there's a service delivery section, health financing, we have community section, we have service delivery, RNMCH. So I can also share my email address and send you once you need it. kimonge@who.int. Thank you, and have a good evening again.
Sorry, samani, naomba msiondoke kidogo. First, I would like to take this opportunity to thank the moderator, Dr. Amanda. And secondly, we have a very short event. We would like to hand over the certificate of appreciation to WHO. So, Dr. Amanda, could you please select someone who would come and take the certificate on behalf? And the certificate will be handed by Godwin Kabalika, who is the country director for Site Saver Tanzania. Karib Godwin.